Hello, everyone, and welcome. My name is Madeline Ballard, and I direct Community Health Impact Coalition, a team of community health workers and aligned health organizations making professional community health workers the norm worldwide by changing guidelines, funding, and policy. We are your hosts today, and I'm tasked with setting the stage for what we hope will be an efficient and action-oriented briefing. Before we begin, I want to make a quick note about interpretation. Today's webinar is being offered in English and in French, so please select your preferred language at the bottom of the screen. Si vous parlez français, vous pouvez sélectionner à la barre de l'écran votre langue préférée. I'm excited to welcome you all today because I sense that while we represent many organizations, we are united in belief, the belief that it's unacceptable for millions of community health workers globally, 70% of whom are women, to work without pay or without support, that this endangers both providers and patients, 1 billion of whom will never see a health worker under current conditions. We know that the future is professional community health workers who are salaried, skilled, supervised, and supplied, integrated like any other health worker into the national health system. And so we yearn together for a present characterized by quality of care for all, including those who provide it. And that's what we're here to talk about today. Because the fact is that because of our collective work, more and more people, institutions around the world agree with this vision. And today we're going to address how we continue to move from the rhetoric of change to the reality of change. Our briefing has 3 objectives, basically to advise, align, and act. So we will first advise. We'll review the case for proCHWs as key universal health coverage and pandemic preparedness and response, as well as their current status in the UHC and PPPR declarations under negotiation right now in the lead up to UNGA. Second, we'll align together around the Monrovia call to action as a key advocacy tool that we can use together at UNGA and beyond. And then finally, we'll launch the proCHW policy dashboard and outline next steps for those who will be either in New York next week or around the world during the UN General Assembly. So we'll be guided today by model collaborators and esteemed experts at their crafts who I'm pleased to introduce. So following me will be Dr. Louis Pearson, Associate Director at UNICEF, proCHWs, a CHW advocates from Living Goods in Uganda, this year's Heroine of Health, Weswa Kwanga, Senior Technical Advisor at MSH, Russ Yarnko, the Director of NCHS in Liberia at Lasma Health, Dr. Lenny Bazira on our team at the Community Health Impact Coalition, Policy Director, Dr. Tessa Aurora Lawrence, our Advocacy Director also at the Coalition, and finally, Thomas Nyango, Country Director, Living Goods, one of our longstanding and founding members. So, a brief note before we begin. I'd say that we have an exciting opportunity ahead of us in the next few days to bring the world's eyes onto the issues that we care about. It's not every year that the UN meets about universal health coverage. And together we can ensure that community health workers and proCHWs are given the attention as an initiative that they deserve at the highest level of government. At the same time, I want to make sure that we carry our shared history into this next week. Since the Alma Ata Declaration in 1978, there have actually been many declarations and resolutions that already say what's currently being debated during this process, that healthcare is a right and that community health workers should be treated like professionals as they provide it. So let's keep the focus this week where it should be, not retreading old ground, but rather moving from awareness to action. Together, if we're aligned, from a messaging standpoint, we know our history. If we know the details of these declarations, we can move from declaration to deed. And to get us going on that journey, I'm honored to pass the mic to Dr. Louis Pearson. of UNICEF.
Thank you, Madeleine. I will focus my presentation on how community health workers as the last mile delivery for primary health care will turn the needle, and how community health workers can be supported in order to produce results. Next. Just to recap, that Africa and South Asia bear the heavy burden of under 5 mortality. And this is also where most countries experiencing insecurity and humanitarian crisis. They are affected by COVID-19, and they're facing climate change challenges. So with all this in one basket, how community health workers could play their role in reducing child mortality, improving survival, as well as contributing to pandemic preparedness and to the health systems. Next. We know in the Monrovia meeting, many country case studies were presented, that in Ethiopia, in Afghanistan, in Liberia, Pakistan, Iran, and many countries, we have seen that community health workers could contribute to improving coverage, use of essential health services, could improve access to essential services in the last mile, even if it is affected by crisis, such as in Afghanistan. And in very well-trained community health workers can be effectively screening and identifying and referral of common childhood illnesses. And they can also contribute to the uptake of family planning, maternal newborn services, as well as generating results, not just in health, but also in nutrition. I'll talk about when I present the case of Iran. And this evidence are important for us to convene dialogue with the government and the partners, so that they understand community health workers are not just consuming recurrent budget by paying their salaries, but they do contribute to the outcomes. And community health workers, if they work well, these are smart investments, but they are not cheap if we do them well. Next. Okay, we are all familiar with the scorecard. There are different ways of making sure accountability by the government or by institutions are realized, and scorecard is just one of the examples where red, green, yellow could be used. And this generates awareness of the lacking behind areas, as well as healthy competition. There's nothing like when your neighbors are doing better than you and you want to do better than your neighbors. So this is exactly where we want to use the scorecard to generate actions. Next. Okay, the Monrovia call, just to recap, is for all of us to work together to support the government-led community health systems through one plan, one team, and one budget. So there are many of us on this call, and how we can collaborate better to make sure that we plan together with the government at national and subnational level, how we work together to support the coordination led by the government, and how we can streamlining our budget to reduce overlap and avoid gaps. Next. is the COVID-19 vaccine delivery partnership set up in COVID-19. That it is a global coalition led by a senior official at the Assistant UN Secretary General's level to take this forward. And we are planning to launch this partnership at Berlin at the World Health Summit on the 17th of October. So this elevated partnership is to ensure high-level political advocacy and align and increase investment, integrate frontline workers into health sector and primary health care system, provide joint technical support, and build mutual accountability. And I hope many of you will join and support this delivery platform. Thank you. Let's move to the next. Okay, I want to, I couldn't talk about the examples in Iran and Ethiopia. The slides were shortened. Therefore, I want to highlight that Iran is a less visited country because of the international embargo, but it is really a well-done primary health care system, including community health workers. When you enter a primary health care center, you're going to be received by community health workers. The first thing you do is to get yourself registered. Even if you're a refugee or IDP, you're going to receive a unique ID. With that unique ID, the community health workers will track you from if it is a child, immunization, malnutrition, and the development milestones, and it will be tracked longitudinally. And if you're adults, female, you'll be tracked for your pregnancy and childbirth and postpartum. And if you're adults, you'll be measured with blood pressure and other screening for adults. And the whole system is computerized. And the community health workers are well supplied. All the medicines are free and covered by national health insurance. Therefore, in Iran, through the community health as part of the primary health care system, have really reduced health burden. They have met the target of MDGs and SDGs 3 target well ahead of schedule. The government made sure they prioritize their budget for the cost-effective interventions, that is primary health care. And I hope we have a chance in the future to look into those case studies in depth. Thank you very much. With this, I just want to conclude that UNICEF is here to support CHIC, to support what you do, and support the countries, the government, and every institutions that are working with community health workers. Thank you.
Thanks, Lue. I'd now like to introduce proCHWs, community health worker, advocate, heroine of health.
I'm proCHWs, professional community health worker hailing from Mityana districts of Uganda. I'm supported by Living Goods and Ministry of Health. My responsibilities encompass assessing and treating of children under 5 years, giving support to pregnant mothers, and giving family planning services, and facilitating timely referrals. As a dedicated community health worker, I'm committed to enhance the well-being of pregnant women and their families through advocacy for safer maternity practices. My approach involves community education on services such as prenatal care, nutrition, and hygiene. I further assist the pregnant women by connecting them to crucial health care services through referrals, linkages, and logistical support. Utilizing both digital tools and my community engagement, I deliver personalized support tailored to individual needs. Throughout the pregnancy journey, I offer counseling, emotional support and guidance, building trust, and addressing concerns. This role has allowed me to bridge the gap between the community and the facilities effectively. During the Ebola outbreak, I adapted my home visits to educate families about signs and symptoms. Given my proximity to the affected districts, I was proactive in preventing its spread by conducting daily roll to identify any new contacts, sharing information on the prevention and management of the diseases, and referring complicated cases to the nearest healthy facility. I also sought advice from my supervisors as I am part of integrated district health system. When the COVID-19 vaccine became available, I led by example, and I was among the first to receive it. I advocated for its safety and effect, using my own vaccination card as a proof. My community trusted me to provide accurate information. During the pandemic, I provide essential guidance to my community, ensuring their adherence to guidelines set forth by the World Health Organization and the Ministry of Health. I focused on fostering their understanding of prevention measures such as proper hand hygiene and maintaining appropriate physical distancing. Effective information dissemination played a vital role in mitigating the spread of the virus. During my involvement in the response team during both the COVID-19 pandemic and the Ebola outbreak in Uganda, I faced challenges due to insufficient personal protective equipment. Nonetheless, I proactively addressed this by becoming a member of advocacy group that advocates for CHWs' rights and necessities, particularly the provision of adequate PPEs and essential resources. The impact of engaged CHWs within communities is visibly reflected in the reduced rates of mortality and morbidity. This effect has notably pronounced during the COVID-19 pandemic and the Ebola outbreaks, with the communities benefiting from active CHWs experiencing swifter recovery. Globally, I'm an advocate. Considering my role as a divine calling, I have successfully bridged the gap between communities and healthcare facilities. Even during the pandemic, when faced with the limited personal protective equipment, I joined an advocacy group to champion the rights and the benefits we rightfully deserve. My recommendation is for all CHWs to undergo advocacy training, allowing us to rightfully claim our place at decision-making tables. I take pride in my participation in the Community Health Impact Coalition since 2020. This affiliation has afforded me valuable insights and avenues for professional growth, and ultimately enhancing my ability to serve my community more effectively. Community health workers should be salaried, skilled, supervised, and supplied. To ensure this, it is essential that proCHW policy dashboard to be launched shortly remains continuously updated as a stakeholder engagement tool. I invite my colleague Waiswa. Thank you.
Thanks, proCHW, for such a passionate call to action. It's great to hear from voices on the ground, especially for those of us working at the global level, and I can't thank you enough. In this part of this webinar, we're going to switch gears and look at what's happening. All know health is a big focus at this year's United Nations General Assembly, with 3 high-level meetings on health, including UHC, TB, and pandemic preparedness and response. There's also the SDG Summit, and there are also other health-related processes that are happening at the same time. I work at the Civil Society Engagement Mechanism for UHC 2030, so we are involved a lot in some of these processes, but mostly in the UHC one. And we understand the essential role that community healthcare workers play in strengthening health systems at the primary healthcare level. And we strongly believe that it is the best approach for health systems to be equitable and responsive to the needs of communities, particularly those left farthest behind. And so it is, this is a very critical moment for us and for the entire community, the community healthcare workers community. This is not just about UHC. It is something that cuts across all the HLMs, across all disease and health issues that everybody works on. A robust and well-trained and well-equipped and compensated health workforce at the community level is key to reaching everyone with quality services that they need. And this can be people with TB, the missing cases of TB. We can only find them through the people on the ground, the community healthcare workers on the ground. And also for pandemic preparedness and response. We can't prevent and respond to pandemics without having the people on the ground that tell us what is going on and alert us to what needs to be done. And so, community healthcare workers play an important role. So we must ensure that when world leaders come to New York next week, they don't just go there and talk business and promise to go back and do business as usual in terms of how they're going to invest, how they plan to equip and train and pay community healthcare workers, but that they make strong, specific act they will, when they go home, commit to implementing. That we have to work very hard, both in the negotiations and the political declarations, but also during the when we were developing our action agenda, which is like a set of key asks from the UHC movement. We made sure, this was earlier this year, we made sure that one of the actions, our action number 4 in that document, that it focuses on strengthening the health workforce to deliver high quality health care. And within strengthen the health workforce by investing to the people that need them. And so we also made sure that we developed a set of milestones that we will use to track progress and implementation. It's not enough to ask, we also have to be able to see and have a way to track what people are doing on the ground. And so that was really what those milestones were created for. But again, these HLMs and the UN General Assembly, they are sort of like the first step toward mobilizing action on community healthcare workers. We would need to seize this opportunity, this moment, and the commitments are going to be made in New York to make sure that we continue that all the way to the regional, to country levels, to shape the implementation. So people can make commitments in New York, really big commitments, but unless you follow through with, you follow up with them, they are going to go back, meaning ministers of health, heads of states, they're going to go back and stay in their offices, lock themselves in their offices, and do the bare minimum they can do. So it is up to all of us to make sure that after New York, that we keep pushing, knocking on their doors to deliver on what it is they're going to do. And then, this moment is also for us to make sure that we don't only focus on engaging the political leaders, but also other stakeholders that will be in New York. You have a lot of members of parliament who actually are the ones who allocate the money to health and all of that. You have civil society, you have the private sector, and others who are going to be important in driving the agenda forward at the region and country level. So making sure that for those of you who are going to be in New York, that you are deliberately planning meetings and when you have an opportunity, having your talking points really ready to go when you have a chance to speak to some of these stakeholders, so that they also help us in pushing after the HLM. Now, the political declarations have been negotiated, and so the question is, what is, they're not finalized yet, but the question is, so far, what are we seeing in terms of community health and community healthcare workers and commitments in those areas? And for the UHC, say that overall, the language is looking good. There is definitely good coverage on the health workforce and specifically on community healthcare workers. There's emphasis on community-led initiatives and community engagement and to strengthen health systems. We have, as the CSM, when we first saw the zero draft back in May, this was one area that we prioritized and pushed very hard along with other partners. There's also good language on scaling up efforts to develop the workforce and compensation and training and all the things that we want to see. And the document also recognizes the role of women in healthcare in the workforce, and also the empowerment, but also promotion in decision-making processes, positions. So, there's some that, but it's like any other process and any other document. It's not going to cover everything, but we have something to start with. On the PPR side, we have seen also, consistent acknowledgement of the need for country-level investment. We've seen strong language in both the UHC and PPR declarations on the community, the centrality of community-level primary health care in both documents. So, there's some traction there, but these documents are not, as some people might say also in this meeting, that they're not as action-oriented as they should be, and so you find some gaps there in terms of emphasis on health as a human right. This is something that, for some reason, governments don't want to commit to and to acknowledge it, but it's very important that they come out and say that. In terms of specific commitments on how they are going to deliver these essential services, you don't really see much of that in either of these documents. The negotiations are reaching the end at this point. There's not much we can do to change them. The momentum with the conversations we have and continue them all the way through the HLM, making sure that even for those issues that are not highlighted in the political declarations, that we continue to build momentum around them. We should continue to use the resources that we have developed at the global level, at regional levels, even health or disease-specific issues. They have developed also their own specific commitments that they want, asks that they want to see, and so we should continue to use those resources going forward. The HLMs, all of them will be live streamed, so you'll be able, if you're not going to be in New York, to see them on TV, and then after that, make sure that you look into the conversation that will happen in the follow-up. I would say that that's all I can share now on the process, but happy to answer any questions, and would like to pass on to Rustam, our next speaker. Thank you.
Thank you so much. And it's great to be here with all of you today. My name is T. Rustam Yango, and I work for LASMA Health as the Director for National Community Health Systems. I'm based in Monrovia, Liberia. So as I just emphasized, strong, efficient, and resilient health system can only be achieved if we all can collectively resolve on these actions. As a pro-CHW movement, we have been on this journey from Monrovia to New York this year, trying to push for the full integration of professional community health workers in the formal health system. In Monrovia in March of 2023 this year, we held the third International Community Health Workers Symposium that brought together multiple stakeholders, community health actors. And in that room, we collectively defined a pathway towards the full integration of pro-CHWs by publishing the Monrovia Call to Action. This document is an important movement for progress for all community health movements globally. What it does is that it highlights our mutual commitment to fund, scale, and strengthen community health programs, and also showcase how it is an integral part of primary healthcare system if we are to realize universal health coverage and pandemic preparedness and response. As we look forward to the UNGA in New York, we must all now elevate the Monrovia Declaration as our North Star. On this slide, we have an abridged version of a sheet version of the Monrovia Call to Action. And as we leverage on high-level meetings next week, our call to action for the UN General Assembly specifically target government stakeholders to make the changes needed to invest in integrated health system. All we are asking them is that they develop clear, costed community health strategies, because it informs resource mobilization, it informs advocacy, it provides a clear framework for legislatures, for donors, for policymakers to make informed, data-driven decisions. Right now, I'm currently out in the field in Liberia, supporting the Liberia Ministry of Health to cost the new National Community Health Strategy. In Liberia, for example, we have been opportune to see firsthand the importance of integrating community health into the health system. So initially, we had just a 3-tier health system. Now community health has been formally recognized as a 4th tier. What we have seen is that community health data has been integrated into one inclusive data collection system. And that has supported pandemic preparedness and response. It has supported immunization efforts, as well as the delivery of high quality, equitable care. Around ensuring that we have a pathway, which is one of the pathways to CHW participation in all decisions, which is one of the key action points highlighted. Community health workers themselves must not be an afterthought. The the experience of other community health workers to help leaders to make decisions. The fourth point here calls for government to ensure that CHWs are formalized, they are paid a fair wage, they are appropriately skilled, they are supervised, and receive supplies to deliver the highest possible quality care. This is the heartbeat of everything we do, and is one of the critical parts of our call to action. For CHW to be effective and reach their full potential, we need them to be recognized just as other health workers for the work they do. If we have any intent of achieving universal health coverage, of preventing the next pandemic, CHW needs to be skilled, appropriately salaried, supervised, supply, and must operate at national scale. The fifth point talks about making sure that people have access to services. And I would just like to highlight this point that cost should never be a barrier for access to care for anyone, irrespective of where you live or what you have. The COVID-19 pandemic taught us a lot of lessons. It showed us how pandemics can impact donor funding and the impact of those funding on health system. It highlights the need for government to invest more in primary health. Today, as we champion the cause for increasing domestic allocations, we must increase our ability to provide accessible, high-quality care in the long term. Finally, for the last call to action, it talks about defining protection for all health workers, including CHW. Community health workers should not have to put their own safety at risk to serve communities. We have the responsibility as decision makers at key community health actors to ensure that our frontline responders to disease outbreak and to everyday health challenges are protected from unnecessary disease exposures, violence, and harassment. Now I would like to hand over to Lina, the Director of Policy at SHIC, to reflect on how we could leverage the largest ever public-facing dashboard on proCHW policies to hold our governments accountable for policy change. Thank you so much.
Thank you, Ruston, for that and all other previous speakers. Good morning, good evening, everybody. We are very happy to be able to share today the proCHW policy dashboard. We've all heard that community health workers are key for us to achieve universal health coverage and be able to respond to pandemics and are part of an integrated health system. However, for this to happen, they need a conducive policy environment. And that's why for us at SHIC, we've come up with a tool, an interactive tool that can be used by all stakeholders for country-level engagement with key stakeholders on the status of proCHW policies and be able to hold governments and other funders and key stakeholders accountable for that. And with that in mind, we looked at different countries, low middle income countries, to see where they stand regarding this kind of policies. Because without policy in place, we cannot be able to achieve all the things we have been talking about this morning. So it's my pleasure and honor this morning or this afternoon, depending on where you are, to officially launch the proCHW policy dashboard. As you can see, as we mentioned, this is an interactive dashboard. It's a tool that covers all the countries from Latin America to Africa to Europe and Asia. It's color-coded, depending on how the countries start. We looked at 137 low-middle-income countries. However, only 91 had data that could be analyzed. And out of the 91, only 34 countries had at least one group of community health workers that is accredited and salaried. And those are the ones you'll see appearing in purple. The ones in orange, even though they have community health workers, they are neither accredited nor salaried. And the ones in blue, they do accredit community health workers. However, they are not salaried. And as you interact with the dashboard, you can click on any country of interest and you'll be able to see on your right the details of the community health workers they have, the groups, and actually also access the raw data we used and the policy details. If you see anything that is missing, kindly fill in that form that's appearing on the screen so that we can get your feedback and continuously update the dashboard. This is a shared resource. We really rely on your feedback as you engage at your country level, and so that we can be able to have all the countries turn purple, so that together we can have and make professional community health workers the norm worldwide. Thank you, and please do utilize the policy dashboard and give us your feedback. And now I hand over to my colleague Tessa to answer some of your questions that you may have. Thank you.
Thank you so much, Lenny, and really great presentations from the whole panel. As you're taking in all the information that's been given during this webinar, please do write your questions. Do send your questions so we can ask them to the panel. The first question that we have is to Louis from our colleague Carrie, who's just joining us back from maternity leave this week. It's great to see the ALMA scorecards, but what specific proCHW metrics are included on the scorecard? And what potential do you see for the scorecard to mobilize political will to make professional community health workers the norm? Over to you, Louis.
If I understand well, is that how the scorecard is used to improve, to promote accountability? And there's a question on what parameters. Is it about how do you set the indicators? I want to make it sure that I understand.
My understanding of the question is specifically what metrics exist, have been included in the scorecard to ensure that, or to measure whether community health workers are salaried, supplied, supervised, and supported.
Right.
And yeah, please.
Okay. So the ALMA scorecard started with malaria indicators, then it's expanded. Now it includes treatment of diarrhea and pneumonia, for example. However, we can also add policy-related indicators if we can combine this with the policy dashboard you just mentioned to monitor resource allocation as well. We can monitor supplies. So it's depend on a country at national and sub-national level. What you see the bottlenecks are, the bottlenecks you want to tackle through the dashboard. For things, the scorecard, for things that are doing relatively well, maybe you don't want to put on the dashboard. Where you want to take on challenges or important matters to monitor regularly. Thank you.
Thanks, Louis. I now shall ask a question to Waiswa about the process currently ongoing at the UN and amongst member states on the high-level meeting and political declaration on UHC. There has been a lot of discussion and disagreement, if you will, around the UHC declaration, and there was a question put by Morgan from Mothers to Mothers on when we expect the political declaration to be finalized and shared.
For some, I think it's my connection. You went out in the last, probably. I guess you're asking when to expect the political declaration to be finalized. Is that right?
Yes, indeed.
Yeah. So we're having the negotiations this year. This is actually typical. They've been quite challenging for all across the HLMs, but for and my response applies to all of them, which is that we don't have any consensus on any of the three political declarations at the moment, but that there's still the President of the General Assembly is still having conversations with specific member states specific things. And we do believe that in the end, consensus will be reached, either before the day or sometime around that. And if it's not reached, there are ways to do this. One would be that we can revert back to the old, for the UHC, go back to the 2019 political declaration, because that has consensus. The other option would be that some of the member states who disagree on specific things, they will agree to the HLM, and then when they come to sit down to endorse the document, they will disassociate themselves from specific provisions of the document, but it will still go through. So they will go through one way or the other, but it's definitely a challenge.
Thanks, Waiswa. We're now going to shift to country level. And Madeleine, there was merci James pour votre question. There was a question about ambivalence, about the integration of community health workers at country level. And James was asking what clear strategies exist to enable community health workers to advocate at national level. I know this has been your work for many years, Madeleine, so handing over to you.
Thanks so much, Tessa, and merci, James, pour votre question. In terms of barriers, I'd say two things. Lue opened the session by saying scorecards can be a powerful thing, that when folks see what their neighbors are doing, or what the country next door is doing, it creates some motivation. And I think that's really why we put together the policy dashboard, to be able to look at the field and see how close we are to actually making professional community health workers the norms. And it's a really powerful tool, because if you're sitting in a country like DRC, where CHWs are not paid and accredited, you can see on that map simultaneously countries that do pay and accredit CHWs that are poorer than your country. You know, Rustin just spoke to us from Liberia, that are perhaps more unstable than your country, that share the particular regional challenges of the place where you live or work. And so it's a wonderful tool to use to sort of challenge the status quo, challenge these immodest claims that this might be too difficult, too expensive, or not worth it, and say, look at the ROI that is being achieved by these other countries, and can we seek out people from those places and ask them, how did you do it, and how can we join in? And I think simultaneously, it's an invitation, if you're listening from a country that accredits and pays CHWs, one that's in purple on the dashboard, and maybe you're thinking, oh, well, our health system isn't that great, we don't have anything to teach anyone, we have imperfections. I'd say that's incorrect. Recognize that actually you're on the vanguard of a global movement that's advancing rapidly, and a movement that really needs you to be people of invitation to reach out across regionally and globally to say, you know, come and see. And the work being led by so many of the community health advocates in this chat to connect across countries and share tactics for organizing national CHW associations that can make these demands is something that we can share more about in the chat and in our follow-up email.
Thanks, Madeleine. I'm seeing a lot of questions addressed to Lue about the ALMAS scorecard. So first question from Michelle is how one can access the ALMAS scorecard. And then the second one from Olasford in Liberia is whether the scorecard is open to making any updates. So please provide said information.
Sure. Thank you for those questions and interest. ALMAS scorecard is a tool online. If you Google it, you'll find it. And it is updated on quarterly basis. What is interesting is behind the ALMAS scorecard is the buy-in from leadership of Africa. It's supposed to be led by the head of states And now we're hoping African Union and Africa CDC in the African continent will take on the responsibilities. The scorecard can be dynamic. It's not internationally standard. There's suggested indicators, but you can change it and adapt it for your local use. And if you need more information, please put your email in the chat box, and we can have more bilateral discussions. We can even include the owner of the ALMA scorecard in ALMA to come to talk to you. Thank you.
Thank you so much, Li Wei. And I see many more questions coming in, but unfortunately, we're at time. There is a question regarding collaboration and how to raise the voice for proCHWs at country level that I would love Ruston to respond to in the chat if you can. I know you've done some great work as Last Mile Health in collaborating across civil society, community health workers, government. So please do respond to that question in the chat. I shall now hand over to Thomas, speaking of country level, to talk about the great work that they're doing in Kenya, shifting policy investment in community health, and to speak about what we can do collectively as SHIC to advocate for community health workers in New York and at home. Over to you, Thomas.
Thanks, Tessa. Thank you very much. Let me build a bit of it. And I was actually reflecting through the discussion, Madeline, when you spoke about a global movement and what a unique opportunity to share how we're moving from both global to country context. Next slide, please. So I'll probably give a bit of overview about the work we do in Kenya as part of SHIC. Of course, I'm the country director of Living Goods. Just leveraging on our core, what I call beliefs and principles, and how do we amplify them and bring them to life in very practical contexts so that the advancement or professionalization of community health work gains the right pace. So that over time, I think just looking back to Lenny's dashboard, we are progressively all becoming pink. I think it was pink or purple. It's a journey. But then there's a lot of great work that makes all of us reach there and even perhaps even strengthen it going further. So a couple of key summaries around Kenya, really what we're talking about, global advocacy informing our country approach. I've already indicated that countries will be at different levels with regards to the proCHW policy wins. And I guess even as you reflected on that dashboard, there are a couple of countries that were not purple, but there's a lot of great work that we still need to recognize that's going on there. And even more still, for those who are purple, there's a lot of work that's still required to ensure that some of these are institutionalized and they're also put within government framework so that they're totally sustainable. As SHIC, part of the SHIC group, we're really supporting a lot of country advocacy efforts. And in Kenya specifically, we are even leveraging other internal partnerships, like one we have in Kenya, which we're calling CHU for UHC. This is an acronym that stands for Community Health Unit for Universal Health Coverage. And of course, it's really pivotal. That really allows all of us to keep reflecting that is really the bedrock of universal health coverage as a fundamental unit. What I want to share with the audience today is, I think we all know and we're hearing a lot about what's going on in Kenya now with regards to community health worker professionalization. And a lot of this great work has started really emanated from both advocacy, but alongside that is a lot of what I call practical steps of organizations with like us and others with similar mindsets, working with governments to make it possible. So allow me to share just a couple of key things which I think have been what I call transformative advancements where we are in Kenya today. One is really around improved remuneration for community health workers, really aligned to our policy or ethos as SHIC on salaried. A bit of context about that is that Kenya operates a devolved structure of governance, and community health work or community health workers are attached to the counties. So they're getting remuneration routinely from the counties. But where we are today, we do a lot of work in advocacy, in championship with government. National government has committed to do a match funding for what community health workers will be given by the county. So national government is going to be giving a 50, so essentially 100%, you know, it depends on how you want to look at it. Whatever county gives, they give a match fund towards that. Again, back to that element of the journey, it may not be a full salary, but I think it's going to be a significant step change in the levels of remuneration of community health workers. The second one, which is a big element, is really around digitization, ensuring that community health workers, all of them, and for Kenya, we have 100,000 across the whole nation, are digitally enabled. And this is going to significantly shift the levels of efficiency, the levels of impact, and the levels of service delivery across the entire country. I think, hopefully we should be one of those nations over the next few months, which has done it 100%. And tied to it, digitization is also going to be giving, issuing community health workers with what I call a standardized revamped kit. That will include, allow them to offer what I call a broad spectrum of services, really aligned to the needs of the community, including even, I'll give examples like screening of NCDs or treating of things like pneumonia, which we know is a big killer. So where are we going from here? What are the next steps? Next slide. Yeah. So next step for us, I know a couple of us will be attending UNGA, but there's also other places, other fora for all of us, all stakeholders around the table. What are the things that we can all do to propagate this agenda and take it forward? One, for all of us who will be at the UN delegations and the different fora next week or thereafter, just ensure that we really amplify our messaging around proCHWs, both at the universal health coverage sessions, but also when we're talking with regards to pandemic preparedness and response. I think the more we amplify this within all stakeholders, whether we're talking about governments, whether we talk about funders, whether we talk about norm setters, and even private sector, okay? I think it's endless. Those are just examples. The better we are in advancing this progress. The second element is really, I know not all of us will be at UNGA, but we'll be in our homes, in our setups with friends, really. Leverage all these networks that we have around us, whether we're talking about social message, social networks, whether we're talking about social media, and even personal and professional circles, really amplify the messaging of all around the proCHW work that we do. Thank you. Next. Thank you very much. Thank you. Lenny, back to you.
Yeah, thank you, Thomas. I think we want to appreciate all our participants, and I'll call upon Madeleine to close the webinar, and then we sign off. Thank you, everyone.
Thanks all. We'll be circulating materials tomorrow, including the recording in both French and English. And we look forward to advocating together this week and beyond. More soon.